All right, hey guys, Rick Bigger. We're going to go over EMS training video today. We're going to talk about altered mental status. We're going to walk through the protocol, kind of the common things that you'll find, how to treat them, and then some transport stuff. When we get done with this video, make sure that you fill out a 1085. This class is worth a half hour of credit. Make sure you get it to your shift rep that's out there so you can get credit for the class. So with altered mental status, we start with the most common things that are out there. Going off of PALS, that we just had PALS training, they talked a lot about having a systematic way to assess people, and that's very important in altered mental status. If you were to QA all the protocols that we use, altered mental status is definitely one where we miss things on the most. We miss some really common things and they find it in the hospital that we should probably be catching in the field. But with the systematic way to assess people, it's always the same thing. You're looking for life threats first, you're treating the symptoms that you find second, and then you're transporting to the appropriate place. It's an easy way to think about it for new medics that aren't as experienced. If you're not really sure what to do, and you're not sure where to go with the call, we have times when calls are confusing, and we're not really sure what you may have a complaint that doesn't necessarily make some sense. So on altered mental status, this could be a very easy one from a nursing home, and you have a common complaint like they're not acting like themselves. Okay, or they're less with it as usual. So when you get a complaint that's not very specific, it can be difficult to figure out how do I assess this person. So that's where the systematic assessment comes into place. Really all I'm doing every time as a medic is I'm looking for a live threat. If I don't find a live threat, then I treat the symptoms I find, and then I transport them to the appropriate place, or I don't transport them if they don't need transporting. But when we talk about altered mental status, what are our life threats that we're worried about? So this is straight out of the protocol. The things that they want you looking for, kind of in somewhat of order here of how this works out, and I've tried to associate these with my treatment priorities to kind of make this make sense. The things we're worried about when a patient's altered, obviously, is a stroke or a head injury. That's going to be our number one. Especially here in Owasso, we have a lot of elderly patients. So the stroke's going to be one of the more common ones, plus it's one of the more dangerous ones. Next is a seizure. Third is sepsis. Fourth is shock, in particular in this case, generally shock that's from hypoxia. There's sugar, and then an overdose. So this is straight from the protocol. These are the things they want you to address, and this kind of address your life threats. So starting with the first one, when we look at the treatment priorities of how do I find these life threats? So number one thing we do in pretty much every call is we're looking for a set of vital signs. That can be achieved while you're still assessing the patient. If you have more than one person there, one person gets a set of vital signs, one person starts assessing what's going on. The next here is stroke scale, so that correlates directly with my first life threat. I'm looking to do a stroke scale. Okay, if it came in as altered mental status, that patient should always have a stroke scale done. Even if they're talking to you, even if it doesn't appear from across the room that they're having a stroke, it takes no more than 10 seconds to do a stroke scale, so it's a good idea to always do that. So we use the Cincinnati stroke scale here. It's pretty accurate as far as finding things in the field. If you're not familiar with that, we start with we have the patient smile, we have the patient grip both of our hands. We do arm drift with their eyes closed, arms out in front. You can also have the patient speak some words for you to see if their speech is slurring. So very quickly, you can get a smile, have them talk to you, have them grip your hands, and then close their eyes and see if they have arm drift. If you have any of those components are going on, then it's a pretty good chance they're having a stroke. If you have multiple components going on, it's in the 90th percentile that you're having a stroke. So we always want to do a stroke scale right off the bat. If I get a positive on the stroke scale, then I need to address the mimickers of a stroke. Okay, so you could have a positive stroke scale and then it actually not be a stroke. So that's why it becomes important that I check the other things. Okay, so positive or negative on the stroke scale, I'm still going to go through the rest of my priorities, but I may go through all these priorities and double right back and decide, hey, this is definitely a stroke. So next on our list there of life threats is a seizure. So with the difference, one of the differences between the LA stroke scale and the Cincinnati stroke scale, on the LA, they'll have you ask for a history of seizures. Okay, so it's very common you have a seizure, and when you're postdictal, especially if you're elderly, that you will get symptoms that mimic a stroke, and then once the patient, their oxygen level gets back up and they're no longer postdictal, those symptoms will resolve. Okay, that's one of the mimickers of the stroke. So it's important to ask if the patient has any seizure history. If you have a patient that's positive on the stroke scale, but they have a seizure history, it's very likely they had a seizure in their postdictal, so we need to assess them further. When you talk about assessing them further, vital signs can be a very good tool there. So I get a positive on the stroke scale. Let's say I have some slurred speech, or maybe it appears that they have drooping of their lips or cheek. And then I ask if they have a seizure history, and they say yes. So then I start looking further, and I look at their vital signs, and their blood pressure is normal, is perfectly normal. The chances of that person having a stroke with a normal blood pressure is almost impossible. So we need to start digging further and try to find out what's going on. So always ask about seizure history to determine if they had a seizure. If we find out that they had a seizure, we're going to move, we're pretty sure they had a seizure, we're going to move off the stroke, and we're going to start digging into that. So is this patient normally postdictal? Are they on medications? When's the last time they had a seizure? Did anybody see them before they were altered? And dig in and try to find out as much as we can about the seizure. If we determine they had a seizure, the important things that are important is, do they have a history, like I just said? If they don't have a history and this is new, they always need to go to the hospital. If they have a history of seizures, we need to find out if they're on their medications. If they are supposed to be on seizure medication and they're not, that patient needs to go to the hospital, because they're going to have more seizures again and again if they're not medicated. Okay, so we need to try to figure out, is this a routine thing that this patient has seizures consistently, they know how to deal with it, their doctor's okay with them staying home, they don't need any further treatment, or they don't have their medication properly dosed, or they're not taking it, they're not compliant with it, or this is the first time. All those things, first time seizures, medication problems, those need to be transported to the hospital. Next is temperature. Okay, so you see on our priorities, so next is we check a temperature. This is one of the most commonly missed things that I've noticed since that I started working in EMS. It's one of the biggest things that people miss on an ambulance. You see this a lot of times, no one checks this, which is one of the most common things you're going to run into, especially with the elderly, for why they're altered. But we miss the most common vital sign that we can find, the most common check we can do to find out what's going on. So with the elderly, if you have 1 degree temperature difference in their body temperature, they will become altered. Okay, so this is one of the most common calls that OWASO runs. From nursing homes, you have UTIs, fevers from all types of infections that lead to a state of sepsis. But the main thing is they have a fever. Once they get a fever, they're going to start to become altered. So we need to evaluate what that temperature is. If we find a fever, it should always key us in. That is the simplest explanation. That's probably what is going on. So we're going to key into our sepsis protocol, and we're going to start looking at it. So the next step on that is to go back to the vital signs. What do they tell us? We had a fever. Is this patient tachycardic? Is their blood pressure, or they're hypotensive? If they are, then we need to move from fever to sepsis, and we need to start treating that aggressively. Sepsis is now surpassing some of your heart attack, stroke, some of your big killers in the hospital. Sepsis is now starting to surpass that. It's a big problem. We're kind of changing the way that, as we all know, working in healthcare, we're transporting people. People live longer. They live in nursing homes. They live in confined spaces. We have different infections that are resistant to medications. We have a lot of reasons why sepsis is on the rise. We also are able to detect it more than we used to. So it's on the rise as a killer that's out there, and treating sepsis early with fluid resuscitation can dramatically change the outcome for that patient. So make sure we're always checking a body temperature. It's very important. It'll also take you, you can have the difference between thinking this person's having a stroke and running them emergent to a hospital for no reason and putting a lot of people in danger, versus finding that they have a fever and they're altered and we have a mimicker. So sepsis is one of the mimickers of a stroke. So make sure that we eliminate it as the cause, or we're able to treat it aggressively. Next here, we go with BGL and our treatment priorities, but we have shock, hypoxia on our life threat there on the list. I listed them this way because that's how the protocol listed them. Our vital signs will obviously be the thing that finds this, and this ties into really all of these. So shock due to hypoxia can be caused by any of these three that are above it. We could have a problem oxygenating due to the damage done by the stroke. We can have a problem oxygenating due to the seizure, and we can have a problem properly oxygenating due to septic shock. So hypoxia and shock ties into all three of those, which is why it is listed, but it doesn't have an exact treatment priority. The vital signs are what would find that for us. Next we go to BGL. Okay, so our blood sugar. We're pretty good at this. This becomes a common thing that everybody checks this on every single call, every time they start an IV. Where we run into problems is when we don't start an IV, when you get one of these tickets where it's a general supportive care ticket, when it should have been altered mental status, and we should have checked these things. So if you have a patient that's complained is altered mental status, general supportive care can never be the protocol for that, because we have a protocol for that. And it requires that we check certain things, BGL being one of them. So if you decide not to start an IV on somebody because you think that, say this patient has dementia, and we go to a nursing home, they have dementia, it gets called in as altered mental status because they're different than normal, and we decide this is a general supportive care call, we're just going to take them to the hospital, have them checked out. Okay, sounds okay, no harm, no foul. The problem is that they have a complaint. It was called in that they were altered, so it's not general supportive care. We use the altered mental status protocol. So quickly, we do a stroke scale, we ask about a history of seizures, we check their temperature really quick, and if we're not going to start an IV, we poke their finger and we get a blood sugar just to make sure, and we've checked we went through all our bases there, and now we know that this is a general supportive care call, and we can just run them over to the hospital. Okay, costs less than $1 to do everything that we just did as far as cost. It takes less than 5 minutes to do all that, and we make sure the patient gets taken care of appropriately, and we don't miss one of these life threats, low blood sugar being one of those. Okay? If we do find this, we all know how to treat low blood sugar. If we do find this, then we go right into the treatment for that. We start an IV, we start fluids, and then we administer dextrose. For some of our newer guys, if you're not familiar, we have switched away from D50, so make sure you review the protocol and you're given the appropriate dose of sugar. Last in our life threats there is overdose. This is one that is missed quite a bit. It's came up here recently, and we've had people treat this and find out that that was the cause with some medication mix-ups. So the last one on our priorities is, does this patient have access to pain medication? It's a very good question to ask at the end of your kind of assessment here of what we're going through. Is there any pain medication in the house? Do they take pain medication normally? And if they're at the nursing home, and do they have pain medication on their medication list? It's very possible that there's a mix-up in their medication. It was possible they're having an adverse reaction to it. And if we find that there is access to pain meds, and in particular, they have access to pain meds and their respiratory rate is slow, as well as they're altered, then we can go right into giving Narcan. So we give 0.5 of Narcan here, unless their breathing is stopped. So we give that 0.5 and see if that fixes their altered status. Okay, so same thing with sugar and overdose. This can tie right back into hypoxia. So that's why our vital signs are on the top. Our vital signs can key us off to any of these in particular, get us headed that right direction. These priorities below it focus us in on exactly what's going on. So as an example, I would most likely, if I have a stroke, I'm gonna have high blood pressure. With a seizure, I can look at respiratory rate and heart rate, can key me into that pretty quickly. Sepsis, tachycardia, hypotension, hypoxia, obviously low SpO2, sugar. Vital signs for sugar is going to be our BGL, and our vital signs we're looking for our overdose is their respiratory rate low, or is their end tidal CO2, is their waveform shallow, and they're not taking full breaths. So vital signs can key us in. These priorities here get us exactly what's going on and focus us in. That takes care of our life threats. If we don't find one of these life threats, then we just treat symptoms that we have. Okay, so the symptom can be as low as maybe they're altered, they're more lethargic than normal today. We're not sure why that is, but since they're more lethargic than normal, they're not breathing as well, and they have a slightly low SpO2, and we simply put a nasal cannula on them or an end tidal CO2 on them and give them a little bit of oxygen, and then we transport them to the hospital non-emergent. Okay, so that leads to the last part here, emergent versus non-emergent. How do we determine this? Okay, so per the protocol, anything that is unknown to us and is altered has to be ran emergent. Okay, so the thing with these are, if I find one of these life threats right here and I can't reverse it, it has to be emergent, right? So if I have a stroke, we do have a time frame on this. Per our protocol, it's currently 6 hours. So if they're last seen normal was 6 hours or less, then we run an emergent per our current protocol. Okay? Seizure, anybody that's actively seizing and we can't stop it, they're emergent. Everybody else non-emergent. Sepsis, anybody that's hypotensive and we can't fix it, that's emergent. Okay, so if I start non-emergent, I give my initial fluid bolus, it has no effect on it, I need to upgrade to emergent because I've tried to treat this and it's not going away. So I need to upgrade to emergent. Hypoxic shock, same thing as well. I found this, it is a life threat, I tried to treat it, it didn't fix it, that's an emergent call. Blood sugar, same thing. If I couldn't establish an IV and I couldn't figure out how to give glucagon, I tried everything, that's emergent. Overdose, I gave Narcan. I know this is a known overdose. I gave Narcan. It worked briefly, went away. I ran out of Narcan. I can't treat it. It needs to be emergent. But most of these that you're going to find, you're going to be able to treat, and it's going to be non-emergent. So, but if I have no idea what's going on, and there's no known cause of altered mental status, it's truly unknown, such as if I became altered. I'm 37 years old and in decent health, and you found me altered at the fire station. You went through all of this, checked my vital signs, went through all these priorities, and you can find nothing wrong with me, but I'm altered. That's emergent, because that doesn't make any sense. I shouldn't be emergent, and I should be treated as unstable. Last on this, the main thing to remember with emergent versus non-emergent is really stable versus unstable. Okay? As opposed to getting into a checklist of this is exactly what you should go, emergent versus non-emergent, it's really up to the medic. Is this patient stable or not stable? Okay, so the example of blood sugar or blood pressure is probably the easiest one. Okay, so this patient's tachycardic, they have a fever, and their blood pressure is low. They're hypotensive. So I can initially say, yes, this patient is unstable because they're hypotensive. They're tachycardic and hypotensive. But I know what the cause is. So I start an IV and I start a fluid bolus. It doesn't automatically have to be emergent because they're still stable at that point. I'm attempting to make them stable. I know what's going on and I'm treating it. Once that treatment's complete and they don't respond, now they're unstable and I need to change what I do. The treatment plan that I had is not working. I need to upgrade that patient and get them to the hospital quicker. So really versus emergent versus non-emergent, we should think about stable versus unstable. Okay? If the patient is stable and it is not time sensitive, such as a stroke, and there's no benefit of me going emergent, then I should run it non-emergent. It's a lot safer that way, and generally speaking, I can treat the patient better when we're driving at a reasonable speed, under control. So any stable patients can be non-emergent. So that's kind of the gist on altered mental status, walk you through the protocol, get through some of our parties. Hopefully that helps you guys understand some of this better. If you have any questions about this, anything that I went through, or anything else that you need to know about altered mental status stuff, let me know. You shoot me a text message, shoot me an email, and I'll walk you guys through it. Appreciate you guys watching. Thank you.